Hi, good morning, good afternoon. This is Ramin Azarm, owner and operator of Flex to Success Clinical Rehabilitation Services, and I'm going to do a video today on bipolar 1 disorder. Now, when discussing bipolar disorder, we know that there's three types of bipolar disorder total. There's bipolar 1 disorder, there's bipolar 2 disorder, and then there's cyclothymic disorder. And there's actually a fourth one. There's bipolar NOS, which stands for not other specified. But the only one that we're going to discuss today is bipolar 1. I am also going to do future videos on bipolar 2 and cyclothymic disorder. I'm just not going to touch on them much today. So defining bipolar 1 disorder, it's basically a mental illness that involves a manic episode of at least 7 days or manic symptoms that become so severe that they require hospitalization. Now, we have to know what a manic episode is to really understand that definition, right? So let's jump into that. A manic episode is a distinct period of abnormally and persistently elevated expansive or irritable mood and abnormally and persistently increased goal-directed activity or energy lasting at least 1 week and present for most of the day. Nearly every day or any duration of hospitalization when experiencing manic symptoms is considered a manic episode. So, what are some of the criteria that we have to meet in order to be considered to be having a manic episode? Well, the first criteria is inflated self-esteem or grandiosity. And of course, I say this every video, these criteria come directly from the DSM-5. For this particular video, I did research some information from NIMH, which is the National Institute of Mental Health. So I did combine the information together, so there may be some things that I discussed that aren't necessarily expanded upon within the DSM-5, so just want to be open and transparent so that everybody knows where my information is coming from. And going back to the criteria. So the first criteria is inflated self-esteem or grandiosity. It's very common during a manic episode for people to have this grandiose sense of mental state, which, grandiosity, as you can remember from some of my prior presentations, like thinking that you have the ability to fly or like lift cars or that you're famous. Inflated self-esteem could be, thinking that you have superpowers, thinking that you can, dunk a basketball when you can't even touch the backboard. Just an inflated sense of ability. The second criteria is a decreased need for sleep. So it's very common when someone's going through a manic episode to report problems sleeping. Also, it's very common for manics to say, I feel rested after like 3 hours of sleep. Yeah, I feel fine. I feel great. Really? You only slept 2 to 3 hours. Are you sure you feel? Oh, yeah. I feel great. Everything's wonderful. So feeling like extremely rested after very little sleep for days on end, there's a good chance that somebody might be experiencing a manic episode or manic symptoms. The third criteria is more talkative than usual or pressure to keep talking. And, one of the things I look for when I'm diagnosing bipolar is pressured speech, meaning like when there's silence, a lot of times as a therapist, I use that skill of saying something and then pausing and letting the patient like process what was said. And usually when you're dealing with somebody who's bipolar and in a manic episode, they won't be able to deal with that silence. As soon as things start to get quiet, they'll have the pressure to start talking about, and then they'll jump from topic to topic. They'll be very tangential, which means jumping from topic to topic, and they won't be able to allow any silence, any period of silence in the session. A lot of times when I see that, I won't jump necessarily to saying that they're having a manic episode, but I'll address the anxiety or the anxiousness. I'll say, oh, are you feeling anxious today? Is this something that's normal for you? How long has this been going on for? Oh, 7 days? Oh, now that's a red. Oh, okay. It's been going on for 7 days or more. Wow, okay. So that could definitely be a manic episode. So that's kind of like how we as therapists like put things together. We look at the duration, we look at the severity, we look at the frequency. Okay? The fourth criteria is a flight of ideas or a subjective experience that thoughts are racing. So you might say, how have your thoughts been lately? How have you been feeling? And the patient might say, my thoughts are racing. I keep jumping from thing to thing. It's very hard for me to focus on one particular topic. My brain is all over the place. I feel a lot of disorganization in my thinking. So that's usually what people experience with flight of ideas. It's like they get all these like ideas of things to do, and like some of them are like vaguely connected, but most of them are like totally disconnected. Like they might have an idea to do some gardening, and then all of a sudden they might get an idea to run a New York City marathon. And then they're off to the races. And then while they're going to the marathon, they're like, you know what, I'm really hungry right now. I don't feel like running anymore. I'm going to go into this restaurant and get something to eat. Then while they're getting something to eat, they're like, I'm just going to drive to another state and see this family member. They haven't called them or told them that they're coming. They just made this decision that they're going to go. So that would be like an example of flight of ideas, where like you're just getting like all these ideas to want to do things, and none of them are really connected to, like one's not really connected to the other one. Or sometimes they're vaguely connected. Like it's like, okay, I want to go play basketball and sleep at the basketball court and then wake up the next day and play again. You know what? I just changed my mind. I'm going to go to a Nets game. Okay, those two things are vaguely connected, right? But you don't have Nets tickets. You don't really have a good, strong plan of how you're going to do it. You just have this sense of urgency. An idea came to your head and you want to act on it right away. So there's an impulsive component, a distractibility component, and those all kind of tie into bipolar disorder and flight of ideas. The fifth criteria is distractibility. Funny, we were just talking about that. So, it's very common to get distracted, especially when you're going through flight of ideas, to be distracted from one idea to the next idea to the next idea. You might see someone and be like, oh, that looks like an old childhood friend. Let me try and call that person and see how they're doing. And it all seems kind of normal, but what makes it kind of abnormal is how fast you're jumping from thing to thing. Like we were talking about before, frequency, duration, those things tends to be very rapid in somebody with bipolar disorder. And if someone's hanging out with that person, they might be like, wow, like you're like all over the place. Like it's hard for me to keep up. Like this is like really intense and fast and rapid, and wow, like this has been going on for a really long time. So just something to keep in mind when you're addressing bipolar disorder, that these are some of the things that you might see, and it might seem really overwhelming. The sixth criteria is increase in goal-directed activity. So, of course, when people are manic, they tend to be very irritable because they're high-strung. So they're amped up. It's like excitement on steroids. That's like the best way I can explain it. They're looking to fly from thing to thing, and even though they're not really accomplishing much or following through on much during a manic episode, they have this intensity with every idea that they get to follow through to the end no matter what. And it's very intense and scary how far somebody with bipolar is willing to go to accomplish certain things. Like they're being driven by an excess of dopamine, which is creating this mania. So they're off to the races. So like if you get in their way, or if you say, hey, wait a minute, hold on a second. Like 1 minute you said you wanted to do this, now you're jumping to a new thing. Like why don't we just finish one thing before we go to the next? That could cause them to just totally become irritated with you and snap at you a little bit. And that's like a red flag that someone's going through a manic episode, when you get in their way and you kind of stop them and say, hey, listen, this is a little wild. I'm not exactly sure what you're feeling right now, but we're jumping from thing to thing here and it feels a little erratic. Can we talk about this? They might be like, screw you, get out of my car. I'm going to do what I have to do and you're in the way. Leave me alone. Bye. And you might just be like, oh my God, like, what the hell? That's a manic episode. Like somebody, has an idea to want to do something and it's backed by some really intense neurochemicals like dopamine. Usually there's an excess of dopamine, like an over access of dopamine when you're experiencing a manic episode. And these people don't want to, they need to be the driver of their own seat, and they don't want to be told to reason or calm down, or they want to go. It's almost like I guess something that could be very similar would be like, and I wouldn't know because I've never tried it, but like maybe like a cocaine rush. Cocaine kind of like causes you to be like very antsy and giddy. Um, and mania is kind of similar to that, where like it's almost like if you've ever done cocaine before, you'd probably know better than me. It gives you like a rush of like can't sit still, restlessness, and like you just want to constantly do things, and it's very hard to control what you're feeling and the thoughts that are coming in. So the next criteria is excessive involvement in activities that have a high potential for painful consequences. And that could be anything from engaging in excessive shopping and going on shopping sprees to making really foolish business investments that cost you thousands and thousands and thousands of dollars, to really inappropriate like one night stand, sexual experiences that are unprotected and excessive. So yeah, I mean, if someone's engaging in these activities on a consistent basis for 7 days or more straight, I would be a little concerned. People that do not have bipolar might do that once and say, oh, wait a second, like, oh, that wasn't a good decision. Like, I need to kind of regroup and come back to reality and be a little bit more conscious in my decision making. But somebody with bipolar disorder who's experiencing a manic episode, they'll make a ton of decisions like that days on end. And until somebody stops them or says, hey, listen, something's wrong here, like you need help, they'll just keep doing it. And it'll be so reckless to the point where they could possibly like die or severely injure themselves or come down with like a health crisis. It could definitely get that bad. So, very important if you see that someone's going through a manic episode, to try and reality orientate them. It might not work. They might just push you away and say, leave me alone. I'm going through something right now. I don't want you involved. Hey, you did what you could. But I would always try to intervene because manic symptoms can lead to really rash decisions with really harsh consequences, just like we were talking about. So, always a good idea to try and intervene if somebody's going through that. If it's unsuccessful, at least you tried. At least you made an attempt to deter them and get them some help. Another thing to consider with bipolar 1 disorder is that, specifically with a manic episode, the mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, or to necessitate hospitalization to prevent harm to self or others, or there are psychotic features. So let's break that down. So these symptoms of mania will often interfere with your job. They will interfere with your friendships, and we're talking negative consequences here. They will interfere with your intimate relationships. They will sometimes lead to psychotic features, which, whenever we talk about psychosis, we're talking about delusions and hallucinations. So you could be hallucinating. It could get that bad. Doesn't always get that bad for people with bipolar 1, but it could. You could start to become delusional, which was like what we talked about earlier with the grandiosity, believing that you're famous, believing that your brother is Tupac or Puff Daddy. These are some of the things that I've heard people say over the years who were suffering from bipolar disorder. And yeah, so very common to kind of tell people things that are totally not true and believe it like 100% when you're going through a psychotic episode related to a bipolar disorder. Also, they discussed hospitalization. So, usually when you're hospitalized, the criteria is you're either a harm to yourself, you're a harm to others, or you have an altered mental status, which means that you're so disorganized and so unaware of reality that you could possibly hurt yourself or somebody else if that's allowed to continue. And that would be judged by a medical professional, most likely an MD or a psychiatrist, would have to make that determination. And when you're taken to the hospital, one of the first things they do is a psych evaluation to find out, are you delusional? Are you psychotic? Are you hallucinating? What is this to the level that requires hospitalization? And then, those doctors would make that decision on whether they need to keep you or if this is something that's going to pass on its own and it's not severe enough to require hospitalization. Another thing to consider is that a manic episode should not be you should not be diagnosing people with bipolar disorder because they're having a manic episode due to a physiological response. Meaning, if the individual has another condition that could be mirroring the symptoms of mania, another health condition, medical condition, you don't want to diagnose that person with bipolar disorder. You want to address the medical condition first. And then once the medical condition is addressed, if those manic symptoms are still there, now we can explore diagnosing for bipolar disorder. But it's always important as a therapist, and I say this in almost every video, rule out medical first. You want to make sure that, this person isn't experiencing something else that's causing them to feel out of sorts, and now you're diagnosing them with a bipolar disorder that's going to stick with them for the rest of their life, and now it goes on their records, and meanwhile they just had an acute short-term issue that was taken care of, and now they don't no longer have manic symptoms anymore. So you just want to be careful of that. You want to do a biopsychosocial evaluation, review all the medical concerns, the psychosocial concerns, the psychological concerns, and then make a decision based on the holistic data collection. Some of the medications that can be used to treat bipolar 1 disorder consist of two different groups: atypical antipsychotics and mood stabilizers. I am not going to go into the specifics regarding medication. If you want, you can consult a psychiatrist for that information. That's not really my depth of expertise. I am a psychotherapist. I mainly deal with talk therapy, but usually when you're treating bipolar disorder, you need a psychotherapist and a psychiatrist, and usually medication and talk therapy are the best combination in alleviating symptoms of bipolar 1 disorder. So I will touch on medications. The mood stabilizers that I've seen to have success with bipolar 1 disorder are lithium, Depakote, Latuda, and Zyprexa. What they do is, when you're experiencing manic depressive, what that is you have periods of mania, which usually are followed by periods of depression, or vice versa, a period of depression followed by a period of mania. Now with bipolar 1 disorder, what kind of makes it different from bipolar 2 is you don't have to have a major depressive episode to have bipolar 1. You can just have manic and hypomanic symptoms. So that term hypomanic is new. And what hypomania is like a less intense form of mania. So you still have the symptoms of mania, you still have elevated mood, you're still hyped up, you still show there's still a lot of overlap. The only difference with hypomania is less intense. So your speech is a little less rapid, your thoughts are a little less disorganized, your speech is a little less pressured, but everything's pretty much the same, it's just less. So hypo means less, So or decreased. So that's hypomania. And usually with bipolar 1 disorder, like you don't need to have a major depressive episode, but you could have a major depressive episode that lasts as long as 7 days or more, along with a manic episode. And that could still be diagnosed as bipolar 1. And a majority of people who are diagnosed with bipolar 1 do have both. They have um, the mania and the depression component, and sometimes they even have a mixed episode, which is mania and depressive symptoms at the same time. So like just rapid shifting of like, I'm manic, I want to do all these things. Oh my God, now I feel depressed. I want to isolate in my room for a little while. Then the next moment, okay, I'm back to wanting to do all these things again and be restless and distractible and pressured speech and all the things we talked about before. And then they shift back to depression. They want to isolate. They don't want to be bothered. They're irritated. They want to be left alone. And yeah, you could definitely have both, but there is a chance that you might only have the manic component. So it's complicated, bipolar 1 disorder, because of that. You have to kind of keep in mind that you could be dealing with different things. And if the person's primarily manic and that's all you're dealing with, a mood stabilizer might not be the best choice. You might just want to go with an atypical psychotic, which is risperidol, olanzapine, ziprasidone, aripiprazole, paliperidone, lurasidone. You might just want to pick something like that, because if you're just constantly up all the time and you have maybe like a mild psychotic component coupled with a manic component, then it doesn't really make sense to take the mood stabilizer if you don't have the opposing depressive component as well. But for people that have the mania and the depression, the mood stabilizer is pretty much a must in most cases if you want to stabilize. Of course, along with talk therapy, and different talk therapies that work for bipolar disorder, and you guys can do your own research on these, is CBT, cognitive behavioral therapy. And then there's another one called intrapersonal rhythmic therapy stimulant therapy. So IPRS, I believe it's called, or IPRST. And those two therapies work really good with bipolar disorder. And reason being is they zero in on specific aspects of the bipolar disorder that are causing the most harm, and they help you to manage those symptoms through talk therapy and coping skills and relaxation techniques. And it's very beneficial to individuals to use both. Studies have actually shown that, so it's evidence-based. So I would recommend both for sure if I'm dealing with someone with bipolar disorder. Of course, you can't force anyone to do anything, but the evidence-based recommendation is that you utilize both. So that's my presentation today on bipolar 1 disorder. It's a pretty complex disorder. There's a lot of components to it. Bipolar disorder in general is very complex because there's 3 different tiers of it. The bipolar 1, the bipolar 2, and the cyclothymic. That's why I kind of broke it up so that I could do videos on all 3, because trying to cram like all 3 of those into one video would have been really disorganized and chaotic. So I hope this was beneficial and educational for some of the people that might be suffering from this disorder, or maybe some of the therapists who have encountered patients who they need to treat with this disorder. And like I was saying before, the main difference with bipolar 1 and bipolar 2 is that you don't necessarily have to have the depressive component to have bipolar 1, but with bipolar 2, there has to be the depressive component. There could be a manic component, but there has to be the depressive component. So that's why bipolar 2 is known as bipolar depression, and bipolar 1 is known as the classic manic depressive disorder. It's also important to note that when individuals do experience the depressive component to bipolar, that increases their risk for suicide. So you should really be on top of your patients who you know have that major depressive component along with their mania, because you know that there's about a 15% increased risk for suicide when you're dealing with those patients, specifically when they're going through the major depressive episode. And just so we're clear, let's go over really quick what the major depressive episode is. So, somebody who's experiencing a major depressive episode is going to be dealing with 5 or more of the following symptoms: depressed mood for most of the day, nearly every day, as indicated by either subjective report, which means the patient tells you that they're feeling depressed. Sad, empty, or hopeless is also considered feeling depressed. Also, observations made by others. So, if the person is observed excessively isolating, crying all the time, tearful all the time, or a majority of the time, that could be considered as a report for depressed mood for most of the day if that's what's going on and it's reported to you. In children and adolescents, the depressed mood can be masked by irritable mood. So when you're dealing with kids who have bipolar disorder, they're going to be a lot more irritable than normal. And that excessive mood irritability should be a red flag that that child should be screened for bipolar disorder. The second criteria for a major depressive episode is markedly diminished interest or pleasure in all things, which is also called anhedonia, when you've just lost the pleasure of enjoying things that were normally enjoyable for you. Significant weight loss is the next criteria, losing 5% of your body weight in a month. Weight gain, you could also gain 5% of your body weight in a month, and that can also be a sign that you might be experiencing some type of a major depressive episode. 5% of your body weight's a pretty decent amount, so it would be cause for concern. Insomnia or hypersomnia nearly every day. Psychomotor agitation or retardation nearly every day. Psychomotor agitation would mean restlessness, constantly feeling like you can't relax, you have to move around, you have to be fidgety and doing something. Tics, all those different kinds of repetitive physical movements. Fatigue or loss of energy nearly every day. That's pretty self-explanatory. Diminished ability to think or concentrate. That's pretty self-explanatory as well. Distractibility. And the last one is recurrent thoughts of death. So recurrent suicidal ideation without a specific plan, a suicide attempt or a specific plan for committing suicide. If somebody tells you that, there is a really good chance that they're feeling depressed. There's a really good chance that they're going through a major depressive episode, because suicide is a major depressive component. So those are the 9 criteria for a major depressive episode. So when I mention that in this video, that's what I'm talking about. Just so everyone kind of has a good idea of bipolar 1 and the different components of it that one could be experiencing. So yeah, I mean, that pretty much sums it up. If you have any questions or comments, please feel free to leave them in the comment section below this video. This will be posted on YouTube. This will be posted on my business Facebook page. So hopefully you guys will watch it and leave me some feedback on how you felt the video was, and if there was anything that I could have included that maybe I didn't touch on. Otherwise, everybody have a great day. Enjoy the day. It's great weather today. And I'll see you guys soon. Bye.